So we'll crack on. So what I've obviously good afternoon, well, good morning. My name is John Jeans. I'm an anaesthetist and I lead the CLEAR program nationally. And we've recently done some work with Dr Neil Hartley Smith, who I'll sort of let him introduce himself at this point before we go on to talk about the work that we've been doing in Blackpool.
Thanks, John. Morning to colleagues joining the call. I'm Neil Hartley Smith. I'm a GP by trade in Blackpool, and I'm also one of the exec directors at the Blackpool CCG, along with Fylde and Wyre CCGs, which are we are a coastal town, for those who don't know Blackpool, in the northwest of England. It gets a bit cold here at this time of the year in my parts. So yeah, pleasure to be here though with you this morning, John.
Thank you. And so we've been doing some work as part of the CLEAR program with Neil and colleagues for the last sort of 6 to 8 months. But before we go into detail to talk about that work, Neil, I guess I wanted to get your view, because primary care has been under a lot of pressure, specifically since prior to the pandemic and obviously post the pandemic as well. And I was just wondering, from your perspective, what impact that's having in the Northwest and specifically on the Fylde coast.
2 words: it's busy. That's probably the best way of putting it. The press that we're getting at the moment, I think, is a little unfortunate, because I think we're finding that most GP practices are seeing patients both in face-to-face and through other digital consultation methods. I can speak to my own practice. When we received the instruction from NHS England to move to virtual consulting back in March 2020, we closed our doors for 7 days, and we figured we can't do this. We've got to see patients. We can't assess abdomens over phones. We can't assess headaches over telephone. So we opened back up, and from that point we have been telephone triaging, and we've been seeing people face to face. It was feeling busier more recently, and I was reading the press, hearing the criticisms. I thought I need to look at this from my own surgery's perspective and get a flavour for what's happening. So what we have always done for the past decade or so, we run a telephone triage system. We've done it for 10 years plus, and patients ring in on the day. If they feel they need to be seen, they go on to this on-call duty list, if you want to call it that. And one of the GPs or a nurse practitioner will call the patients back. We've not changed how our surgery works. Nothing has changed about the way patients access the service. And so what I was able to do is a direct comparison back with 2019. And I looked at the summer months, June, July, August of 2019, and did a direct comparison with this year. And in terms of the call volume actually going onto that duty list, we are up 25 to 30%. Now, I can tell you in 2019 we were busy, and therefore an extra 25, 30% on top with no additional workforce to be able to put against that, it gets more challenging.
I mean, these are quite substantial numbers, sort of 25 to 30% increase in the volume of patients that are accessing the service. And I suppose, obviously, your surgery is in actually one of the most deprived wards in the country. What do you think? What impact do you think that has, and the pandemic has, on the patients that you see, but also the patients that you don't see? How do you think the health inequalities plays into it?
Well, you're quite right to mention, John. To give an example, to quote some numbers, life expectancy of a male child born in Blackpool between 2018 and 2020 is 74.1 years, which is the lowest in the country. And if we look at that within Blackpool, just within the Blackpool sort of radius, that life expectancy can vary up to 12 years from the highest to lowest areas of deprivation. We have high levels of smoking, we have high levels of alcohol misuse, substance misuse, we have high levels of obesity. People don't exercise as much as they should do. People aren't as activated into looking after their medical conditions. And I think this starts much earlier. We have high levels of unemployment, both through disability and inability to find work. The town, being a seaside town, brings with it swathes of seasonal employment. So you get good employment for half the year and high rates of unemployment for half the year, which also then brings huge transiency to the area. So and then combined with that, the children leaving school leave with significantly lower levels of educational attainment than what you would see in more affluent areas. It's a perfect mixing pot for poor health outcomes, and we see that. We see our hospital just at the moment is on, well, we have no beds. We've got ambulances outside trying to get people into the hospital. So COVID has just added an extra layer of problem on top of what was already a problematic area. The Chief Medical Officer's report for this year, Chris Whitty, does mention the specific issues that seaside towns face with the health inequalities. And we, despite best efforts, we continue to struggle. And when we started speaking to Claire, one of the things I was looking at is how could we be more efficient? How could we spend our time actually dealing with the problems rather than trying to react, be proactive as opposed to reactive? And that probably is a good point to maybe start talking about some of the stuff we've perhaps been looking at, John. I remember when we first started this project, the initial brief, and correct me if I'm wrong on this, but I think the original brief was to look at how we were utilising appointments within the surgery. Which was a great idea to start because we were wondering whether we were using our time appropriately. But as we started to work through, I think it became apparent to us that there was perhaps a better way of looking at this work. And we were seeing primary care networks starting to form. And one of the things I've always thought with primary care networks is they do provide a unique opportunity to work with economies of scale. Things that general practice has never had the opportunity to do before. We've always had to have our own nurse who does COPD and another one who does diabetes. So if we're lucky, we could get the two skills in one nurse, which was a real, that was a good day. But what we could then start to say, if you're looking at a population of 30 to 50,000, which is a typical size of the primary care network, do we all have to have a nurse who does COPD? Do we all have to have a nurse who does diabetes? Or could we start to share that amongst us? So I think I also mentioned some work I'd done many years ago in an A&E department, which had looked at staffing levels and looking at patient cohorts, etc. And one of the things that we then moved on to do was to say, okay, why don't we look at what the patients are doing? Traditionally, when we look at how to staff something, we typically look at what disease burden we have. And what we said is, how do we look, well, we pick a disease, we pick diabetes, I think. So how do we look at what is good diabetes care? And we've said we'll look at the patient activity and what churn those patients are developing in the system. And through a process of meetings and refinements, we started to gather a data set, which was interesting, I think is the word to put to it, because it was throwing up things which we weren't particularly expecting. Well, maybe it's worthwhile just mentioning, in Blackpool, as part of the Vanguard programme, which was many years ago, we developed what was called an extensive care service, which was to look at the frail, multiple morbidity type patients and put wraparound care with them using, OTs, physio, etc., recognising that people with multiple problems generate greatest work. That's always been the thinking. What we started to see in some of the work that your team were pulling out, John, was actually that could we question that traditional wisdom? Were there patients who perhaps were not at that advanced age, who perhaps didn't have 5 or 6 different chronic diseases, who were generating significant churn in the system? I'm realising I'm talking quite a bit, John. I just want to make sure is this helpful, or am I going off track a little?
No, I think Neil, I think that's exactly the point. Is that when we started to obviously there was as you said, there's a need in general practice to work in a slightly different way, given the significant demands that we faced, and especially in areas like Blackpool, which have significant levels of deprivation. And so one of the things that we've been trying to do over the course of this project is to look at the different patient groups and figure out how we can look after those patients in a more effective manner using a multidisciplinary approach that gets the right staff looking after the right patient in the right way. So not thinking about diseases per se, but thinking about patients and how we wrap a workforce around those patients in the most effective manner. And I don't know, Neil, do you think it's useful for me to go through some of the data that we looked at and some of the thoughts?
I was going to suggest it might be, yeah, because I mean, I know we've had many a morning where we've sat down and pored over the fancy graphs that you produce, something like that. I look in awe at some of these graphs and think, what does that mean, really? So, yeah, if you could explain the graphs and the data, that would be great, John. Thanks.
Absolutely. So what I'll do is I'll just go through a couple of slides. I'll just have to sort of enable my screen sharing. I don't know if that's something that could help with Charlotte or Suman, but what I'll do is just go through a couple of slides and just talk through the challenges that were faced by the by by the practice. So just to check, can everyone see my screen and the
Yes.
slides on the screen? Yeah, fantastic.
Yeah.
So what after a lot of discussion, as Neil sort of alluded to, what we did is we took an extract of the data from the GP practice, and the extract of the data was de-identified patient level data. So what that means is data that you can't identify the patient, or I couldn't identify the patient, but there was a mechanism where if the data was handed back to Neil, he could identify the patient. And obviously that had a very robust IG agreement around it, Neil. I don't know if it's just worth going into that in a little bit more detail, because one of the things that obviously we're both very concerned about as clinicians looking after our patients is that the data is used well. And I don't know if you want to just go into the bit more of the nuts and bolts of the process and the robustness of it, because I think it was something that we both thought a lot about before we did the data extraction. Is that a fair thing to say?
I will try my best to explain what your clever guys did. One of the biggest problems we always seem to hit when we've tried doing these projects with other people in the past is that information governance rules. And people, I think, sometimes are actually put off by engaging in projects of this nature because of those worries. Because, you know, since GDPR came out, we're all under the threat of the 20 million euros maximum fine that you can be given for a data breach. So that's a significant chunk of money. It's more than John makes in a year, I think. But what we were able to assure ourselves at the practice is on the data extraction is that, as John says, the data does not contain anything for that John's team could identify in any way. But reassuringly, to sort of quality check the data, John was able to give me key identifiers back, which were to him meaningless numbers. To me, they were numbers within my computer system that I could look up a patient's record on. And that gave us that, you know, I was able to then look at it remotely from John when we were trying to look at the data to say, well, is this useful data or not? We, on a couple of occasions, we took those numbers. I looked at the data at my end and was able to relay back to John again in an anonymized fashion what the data was showing us. So I was able to look at my patient's records. John was on a screen elsewhere in the country, and we were able to discuss, was this useful information or not? I was completely assured that there was no chance of any of your team accessing any data which would have been inappropriate. And certainly my practice manager, who's also our data manager, was also assured by the process that the team brought. So it's definitely, yeah, I think that's important that possibly when we're looking at doing these projects, that's probably one of the first things to discuss with any prospective sites is that is the thing that will be taken as the one of the real sort of paramount factors, that the data and patient confidentiality overrides everything else. So yeah, that helps.
Yeah, no, completely agree, and I think that's something that is just important to state up front before we start to go look at all of this data, is that all the data that the CLEAR program uses is de-identified patient level data with a very robust IG process around it that has appropriate information sharing or data processing agreements with DPIAs performed. So yeah, I think that's very helpful, Neil, that we've been able to discuss that in front of this in this forum here. And so once the data was extracted, what we were able to do is to look at it in its entirety and look at it through a range of different lenses. And as Neil said, we started off by thinking, is the key issue here for this patient population, this increase in workload, should we just look at patients that have diabetes? And we looked at patients that had diabetes and we thought, actually, these patients are managed reasonably well, but they're not necessarily causing what all of that excess demand is. And then we thought, okay, well, should we look at COPD? And again, we're sort of able to look at it and, okay, there maybe could be some more spirometry done here or that sort of bits and bobs there. But actually, there wasn't a convincing argument that these particular patients were causing system-wide demand. But what we were able to do by looking at patients via the number of A&E attendances that they had, we were able to find a small cohort of patients, about 3%, that accounted for about a third of system spend. And what we were able to find is that actually a relatively small change in the workforce that could wrap around these patients could actually cause a significant benefits for this patient population, and in terms of reducing the amount of demand that they placed upon the different they're placed on different services across the system. And there was a couple of ways this could have been done. One was by using sort of a relatively small workforce, a small team comprising of a couple of days a week of time from different different staff members. So 1.1 WPs in total. And what we found is that if this particular group of team, that 1.1 WTs in total, was able to, for 47 patients, reduce their A&E attendances by 10%, reduce their primary care appointments by 5%, and reduce their hospital attendances by 5%, the investment in that team would have been cost neutral and freed up a lot of time within general practice to look after these patients in a more effective manner. So that was the first workforce model that we came up with. The logic for this workforce model was as follows. In the practice, there's about 18,000 patients in total, and of these 18,000 patients in a given month, about 3,400 3,400 patients turn up or are seen by the practice or generate activity within the system. And this patient cohort generates about 2.3 million pounds worth of cost. Now, if we look at this patient cohort of 3,400 patients, around 280 generate 5 or more ED attendances. And of these patients, 830,000 these patients, they generate about 830,000 pounds of cost. Now, if we look at all the different types of patient conditions that these patients have, there are a plethora of different types of conditions. And the presentations that they have, again, very, 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 lots of different types of presentations. And so what this showed us is that actually this wasn't just a disease-specific problem. This was, as we discussed, a patient, a particular type of patient cohort that needed further investigation. Obviously, within this patient cohort, diabetes did have some cost. As you can see here, this particular patient cohort of type 2 diabetes had around 170,000 pounds worth of cost. But if you looked at all these different patient cohorts together, they, it's still, they're just targeting the diseases wouldn't generate all of the solutions. And I think, Neil, at this point, it's probably worth saying we actually looked at the data to cohort the patients at a high level. But we also then did a bit of a sort of an analysis where, as you said, some of the numbers came back to you and you had a look at them. And from your, what was your opinion of looking at sort of the sort of the small section of patients that we analysed? Because what we're sort of showing some disease here could make a difference, but did that feel like the right thing to do to tackle specific diseases when you looked at the actual patients?
Not when you actually drilled down into the records, once you provided the data back. It became quite surprising, actually, that some of these patients were completely off the radar. They were children, and then I thought, well, that's strange. And then the others were in the 20s, 30s, and 40s. Now, what we do, it's worth mentioning that what we do see in my surgery is we do see advanced chronic disease at a much earlier age. So we are seeing end-stage COPDs in the early 50s in some cases, and people who've had 3 or 4 MIs by the time they're hitting 50. And these are not familial hypercholesterolemia type patients. These are just your typical residents of the area. But these weren't the patients we were seeing. These were younger patients who wouldn't necessarily hit that sort of traditional radar of, if you're on 5 or 6 medications, you should be a target, or if you have 3 or 4 chronic diseases, you should be a target. And when you started to look at those attendances that churn in that system, a lot of it wasn't particularly medical. A lot of it was more sort of, is the patient been educated in the right way? Are they attending there because they don't know where else to go? Do they need a more wraparound support, which is not necessarily your traditional, you need more diabetes medication. It's you need just a help and a hand in understanding what your symptoms mean, or if you are feeling upset, would you turn to the support for that? And so there was a strong sense that the mental health played a significant role in a lot of the presentations we were seeing, but it was being coded through as other disease. So I think what my surprise was that, of my diabetics, of my COPD patients who were generating a significant chunk of that churn, it wasn't about my management of diabetes or my management of COPD, which was likely to make huge differences. It would make some difference. There's no doubt that getting good management of those conditions is important. But it's the bit that wraps around the patient, which seems to be something which we want to look at in more detail to try and investigate this, as we move forward, because that's certainly where the data pushed us.
And on that point, Neil, we also had some. Excuse me. It's not a new cough, just in case anyone is wondering. So we've got. So we did have a look and some constructive challenge from some colleagues around the data, and specifically around whether or not these patients that we had identified were going to need consistent and continuing care for a number of years, or whether or not it was sort of a one-off spike in demand. And from your perspective, do you think that the data was rich enough to be able to sort of answer that particular concern about whether or not this patient cohort? Because what we don't want to do is build a new service for a patient cohort that's only going to need it for 3 months of the year, and then not need it again. And were you confident with the data that these patients we identified were going to need a service that would need to be stood up for a number of years?
Again, going back to our previous experiences with the Vanguard project, which adopted this American extensivist type care, that did show to have significant benefits with the target cohort that it looked at. And I suppose I'm making a bit of a leap of faith here in saying that actually that wraparound care worked really well in that set of patients. It could work well here. And there's the way to try and prove the theory is to do a small scale trial and rerun, for 6 months or so, and rerun the data perhaps. But I think just on that point, what I would like to do is perhaps expand the data set up to a PCN, because I'm mindful here that the data that we are using is my practice in my area. And whilst my PCN is, you know, it's not a huge geographical location, we do see that the levels of deprivation and, you know, wider determinants of health do vary widely amongst that PCN. So it would be really useful, I think, to say, engage further with yourself, John, and gain more data to kind of assure us that what we're looking at here is translatable to a wider population. And that will be, I think, my ask for the next steps with this. But I do, in answer to your original question, I think from what I've seen so far, there is enough to convince me that a trial of this type of work, wrapping that curve around for an extended period of time, would be something that we will be looking at within our PCN. But as I say, the extra data would also be useful.
I think I can completely agree. I think one of the, when we initially started doing this piece of work, we were only asked to look at one practice, and what has become clear is that actually doing this work at a PCN level is going to add a lot more value. And I mean, Neil, I think it might just be helpful because we did end up looking for two sort of workforce models in the end, one that was disease specific and one that was sort of patient specific. And if I just flash those slides up quickly, so that as sort of everyone is aware, I'll just go on to the big screen here. What we were able to do is identify a range of different, a cohort of patients that were sort of high use patients. And it didn't matter which month of the year you looked at, these patients always existed, somewhere between 200 and 300 patients a month, generating a significant proportion of spend for the practice and for the system as a whole. And these patients existed, as we sort of discussed, no matter at any, you know, all the time. In essence, it wasn't a case that this patient cohort came for a couple of months and then left. This patient cohort was sort of all there in the background, generating significant demand over a period of years, not just a period of months. And so we came up with a couple of different sort of service targets and offerings with different models of workforce associated with them. And obviously I can share these slides more widely to everyone on the call afterwards, because I'm going through this relatively quickly. And the two services were basically a focus service on diabetes, which I've sort of already alluded to, which had the 6 clinicians working as part of a wider multidisciplinary team working on just patients who had diabetes. And a second one, which was much more broader and holistic, and that had a much wider workforce model, looking at a range of different interventions. And the cost of the service for the wider workforce model was around £143,000, but with a sort of a 10% reduction in demand across the system, the savings of this would be quite substantial. And I guess, you know, obviously, Neil, we're going to go on to have further conversation systems to which of these two models is likely the most sensible one to roll forward with. But from your perspective of going through the process of having a conversation around the data, applying that local knowledge of your patients based upon and then aligning it with the data available, and having the opportunity to think a little bit outside the box and creating that headspace to think about things differently. Which of these two service models and workforce models do you think would be the most appropriate, given where we've got to? And I'll just come off the screen share at this moment in time.
The assumption is, first off, you can get the workforce, because that is a significant issue for lots of surgeries at the moment. But my inclination is to look more down that sort of extensivist type care and that wraparound for not just one particular disease subset, but to go with multiple diseases, because I think by doing that, a lot of the problems I think we will find with the patients are very similar and not disease specific. So as I was saying, that sort of mental health, well-being type stuff, that will be the same requirement, I believe, irrespective of what disease we're dealing with. So your sort of social prescriber, so well-being workers, etc., they will work quite happily across that a range of diseases. And I think by doing that, you cover more ground more quickly. And I think you just mentioned then, John, I think it's translating this up beyond PCN to sort of place-based partnerships. So looking at it as a place, if you could operate in this way, you could very easily develop significant efficiencies across the place, which also then potentially translates on reduced activity within our acute trust. And as we all know, with the times we've just lived through, if we can spare, bed spaces for acute illness, that is something that is highly desirable. And actually, it's not desirable as a health service employee. It's desirable as a patient. You don't want to be in hospital. The best place for any patient is at home, and not in a bed. Yeah, being in bed for a day adds years onto you. That takes years off your life expectancy. So irrespective of the numbers, if we cite this around the important person, which is the patient, developing a system where you're not entering the hospital all the time and being exposed to multiple investigations, etc., which, nothing is without risk. If we can avoid some of that risk for the patient and at the same time save money to reinvest within our healthcare system, I think, I'm always looking for a win-win, and we're heading in that direction.
Absolutely, Neil. I couldn't, agree more. I think, as many on this call, some on this call may know, the reason I got into this work is because my dad didn't get the kind of care that was joined up across the system, and that ended up to him not having the outcomes that I think we all would have wanted. So I think, with the data and the money, we can get, oh, this is efficiencies, oh, this frees up activity, but actually we're in this for patients. And I think if we can use this kind of methodology to wrap models of care and workforce around patients in a way that tangibly can be implemented, and this feels like something that tangibly can be implemented on the Fylde coast over the coming months potentially, then I think that is, it's why we come into healthcare. So I'm a bit conscious of time because as Caroline sort of warned me before the call, if you give me some opportunity to talk around the data, and I'm sure Neil, we're as guilty of this as well. We could probably talk for hours. But I was just wondering, I don't know if Neil, if you've got any final thoughts, or if it's a sensible time to open up to colleagues on the call to see if there's any questions about this particular work or anything, or any thoughts that people want to share. Does that seem like a sensible thing to do, Neil, given where we've got to?
I'm sorry, my connection just became a little unstable then, John. I don't know if you can still hear me.
I can hear you fine.
Okay, so I didn't hear what you said. Could you just repeat?
Oh, no, sorry. I was just suggesting that we've sort of probably a good time to open up to colleagues to see if there's any thoughts or questions.
Oh, yeah.
And actually, we've probably got a small enough group.
Yeah.
Small enough group so that if people don't want to write in the chat but want to ask a question and take the video off, then obviously very happy for that as well.
Absolutely.
I think just looking on the oh, Helen just popped up. I don't know if that was going to ask a question or not.
Morning.
Hiya.
Hi. Thank you so much for that. Neil, we're just up the road in University Hospitals of Morecambe Bay, and I'd be really interested in linking in with you around a little bit more information on this. Obviously, you've only got so much time to share, which has just been great, but I can see so much, just so much opportunity about how it links into the work that we're doing around our community operating model, and I really like the idea of when you're following your patients and actually where do they go, what are they choosing. So if that would be okay to link up with you off.
Absolutely, not a problem at all. Be very, very happy to. And I'm sure if you have any questions and I can't answer them, I'm sure John will probably be happy to
Yeah.
as well. As I say, I'm speaking for John there, but hopefully
he was nodding anyway. I just think it's so difficult at the moment, isn't it? It's like which way do you turn, and you know, the patients are choosing what they think is the right thing, and working different. That local knowledge is really, really important, and small chunks, because there's not one big thing that's going to make a difference. We're going to have to work together differently. So yeah, I'm really, really interested in linking up, Neil. Thank you.
Absolutely. And I think just to speak a little more to what you were saying there isn't one solution that works for an entire place, or ICS or ICB as we're now calling them. Names changed by the day. And the real good thing about what we've been trying to develop here, in my opinion, is that it's your own patient cohort. It's very much focused on the activity that's being generated within a practice or a primary care network. So it is locally responsive. We're not trying to apply a singular answer to everywhere, albeit the searches will be the same. The outputs of the searches might, in other areas, give different models of care required for outcomes. Yeah.
But it's about making sure that what we're providing is absolutely the right thing, and not lots of things that are not the right thing at this time, and being really flexible and agile for what, that's about.
The other thing I think is worth, I maybe said this earlier, is this is looking at things from a completely different angle. This is looking at the activity of patients, not what disease burden they possess. So, we've traditionally looked at, people who have multiple diseases, and as I say, this is just turning a little and looking at what patients are churning through the system.
Yeah, perfect. Thank you.
Okay, thanks.
I've just seen, Janet, that you've had a question of, do you link in with any community care such as parish nursing? And obviously very happy to answer that question, Janet, but I don't know if you want to broaden it out, or if it's just that direct question that would be helpful to discuss right now.
No, it's just I'm also kind of in between Morecambe Bay and Blackpool, and I'm working for the Lancashire and South Cumbria ICS, but on the diagnostic imaging. But it was just a question more from a personal point of view, because I know churches in Lancaster are opening there's one particular opening a community family and life family centre, and they're intending on providing parish nursing, and obviously that's quite a holistic approach to care. And I wondered if you in Blackpool had links like that could be formed.
My computer just froze again, so hopefully you can still hear me. I think that is a marvellous idea. We don't have access to it in my particular area. I also do work as a GP appraiser, and I was talking to a GP colleague who works in Preston, who does quite a bit of Christian counselling, is what she told her, and that was quite fascinating, how people, parishioners from her church, will work in a similar way and provide that sort of wraparound support for.
Sorry, I think he's frozen.
We're able to immediately.
Yeah, I mean, it's beyond counselling, Christian counselling. It's proper nursing is what's going to be offered. It's not just Christian counselling. It's about looking at the whole. It's not a Christian thing in some ways.
But no, we don't. We're not using that just at the moment. Sorry, have I misunderstood?
No. It was just whether you had links with that, because I think they're quite useful.
If you are able to share anything with us, I'll be more than happy to have a look at it. Absolutely.
Yeah, it's just something. I mean, it's Lancaster based, not Blackpool based, but it's similar work, linking in with social services and all of it, really.
Yeah. Well, thank you for
Yeah.
making me aware of that, though. Thank you.
Okay, well, I think we had sort of 40 minutes booked for this session, and we've gone a couple of minutes over. So I guess, final check and see if there's any more thoughts or any more questions that anyone has. And if not, we'll bring this session to a close. But thank you. Just do a quick scan, see if there's anything that pops up. But no, not this moment in time. Okay, wonderful. Well, thank you very much for your time, everyone. I really appreciate your attendance, and hopefully you've been able to take something useful away from it. And if anyone does have any further questions or thoughts, please don't hesitate to get in touch, and have a great day.